Welcome to CellTalk webinar. Today's presentation will be given by Dr. Divya Lakshmi Ramakrishna. So, a short introduction before the presentation. Dr. Divya Lakshmi Ramakrishna is a scientific content writer and team lead at Phoenix Life Sciences since 2 years, where she has gained experience in operational, managerial, administrative roles along with scientific activities. She has an explicit writing skill to present the articles in required formats such as the blogs, white papers, disease summaries, descriptions, posters, and reviews in various medical specialties with main focus on oncology. He is involved in enhancing the scientific research content collected from wide spectrum of literature to reach the target audience like patients, healthcare professionals, and clinicians. Currently, she is actively involved in the content creation of Clinical Gene Maps project. Presently at Phoenix Life Sciences, she is managing multiple teams like the content team, the data acquisition team, and also the health analytics team. And she is successfully completing the deliverables from these teams through planning, task allocation, guidance, reviews, and approvals. She is also experienced in proofreading, editing, and reviewing of documents written by other team members. Recently, she has played a major role in the initiation and execution of major projects related to healthcare monitoring of senior citizens and rural health care programs. So, before further delay, I would like to invite Divya to take the floor and start her presentation.
Thank you, Numed, for this elaborate introduction. So, today, the topic of my presentation will be the artificial intelligence based prediction of lung cancer risk using non imaging electronic medical records, which is a deep learning approach. The original author is Ye et al. And it is this article is selected from the Journal of Medical Internet Research with an impact factor of 7.07, and it was published in the year 2021. Now, starting with the introduction, as you all know that lung cancer is one of the most common cause of death worldwide, and early detection is very crucial. And this early detection is very much essential also because screening these target populations is recommended in order to reduce the mortality rate. Now, there have been various parameters which are frequently involved in identifying self-reported information such as the family history, BMI, socioeconomic status, smoking cessation history, which have been used to develop multiple models. In this present study, the National Lung Screening Trial of Taiwan revealed that the screening with LDCT, it can reduce the mortality associated with lung cancer by 20%. But the potential hazard of radiation exposure and false positive results, and also the cost associated with LDCT, has suggested that the annual screening of the targeted high risk individuals is recommended rather than the complete population screening. Now, because of this potential harm which is associated with the false positive results and also the cost effectiveness of LDCT, so this LDCT screening is again very controversial whether to be used in targeted or high risk population or in the whole population. Now, in order to overcome this problem, multiple research groups have developed various risk prediction models to classify patients who might benefit from LDCT screening. Now, the use of artificial intelligence in this area has resulted in good performance for predicting the image related task, mainly by the use of CNN, that is the convolutional neural networks. The prediction performance is mainly based on the high level feature extraction and the non-linear prediction by the use of neural networks. But the challenges here would be that though early diagnosis and screening for early diagnosis is the key in lung cancer, and various data sets have been used, like the blood and tissue data, omics, risk factor assessment, imaging, EMR, based on the artificial intelligence approach. In this study, EMR based artificial intelligence approach has been used. Now, multiple researchers have attempted to come up with risk prediction models for the diagnosis of lung cancer, but later these individuals can undergo LDCT. The radiation exposure again and the cost which is associated with CT is questionable. So the use of a predictive model to identify individuals at high risk, it can help to limit the unnecessary exposure of the patient. In this scenario, the author's objective was to develop a risk model for the prediction of lung cancer using data from the electronic medical records, and by this it can facilitate the prospective identification of individuals at higher risk of developing lung cancer, and further these individuals might undergo follow-up examinations including imaging, that is low density computed tomography. Coming to the methodology of this study, it included participants between 20 to 90 years of age with at least 4 years of medical records on the file. The data of the the first diagnosis was based on 3 years of patient medical information to predict the risk of new onset lung cancer at or within 1 year later. And for each of the patients, the diagnosis and the medications prescribed at each visit was recorded, and this was converted to an image like array which preserved the temporal information associated with both the diagnosis and medication history. The inputs like the age, gender, and an image representing the 3 year patient history of diagnosis and medication was included. And this image was input into the exception, which is a 126 layer neural network in which feature extraction was performed. And participants with any of the missing data were excluded from the study. A total of 3 subgroup analysis was performed in this study in different populations. First thing was the age criteria, where the patients were categorized into the age of above 55 years and below 55 years. And this was based on the age criteria used in the previous trials focused on the lung cancer screening. Then the second categorization was based on the patients with and without previous lung disease, which and then the lung diseases which were included were patients which were diagnosed with asbestosis, bronchiectasis, chronic bronchitis, chronic obstructive pulmonary disease, emphysema, fibrosis, pneumonia, sarcoidosis, silicosis, and tuberculosis infections. Then the third subgroup was the age and the gender matched control. Now, this is the exception network, or for each patient, this was the model which was used for analysis. Now, coming to the model construction and evaluation, all the patient data was split into the training, validation, and the testing sets, which was based on the respective index date. And the data with the index date prior to December 31st, 2012. It was used for training and internal validation, whereas with index dates after the date, it was used for prospective testing. The patient's age, gender, and the image arrays described above were used as the inputs for the generation of the model. This model was trained to determine whether a given patient was likely to develop lung cancer within 1 year. And this exception architecture included the 126 layer CNN based neural network with moderate number of parameters, which was used for feature extraction. The performance model was then assessed for its sensitivity, specificity, and also area under the receiver operating characteristic curve. And to understand the model prediction, the occlusal sensitivity analysis and also dimensional reduction technique along with TSNE tests were performed. And the model construction, pre-processing of the data, model training, and the statistical processing was performed using Python programming language version 3.6. Now, coming to the results, now the total number of data sets after the was 2 million, and the initial screening, after the initial screening was done, the patients under the age of 20, above the age of 90, and sorry, and with the missing or the incorrect data were excluded. Then the patients with diagnosis of lung cancer and the control, this was the number, and this was the exclusion criteria where lung cancer was not the first cancer of diagnosis, that is metastatic cases were excluded. Then patients with incomplete 4-year data before the index date and do not have an card or an intervention code. And also exclusion was incomplete 4-year data after randomly selecting the indexed day from the records. So a total of 11,617 lung cancer patients and 14,23,154 control patients were identified finally in the data set. And the mean age for lung cancer group was 66.62, and it included about 59% and 40 men and 40% women. And as mentioned before, the participants were between the age of 20 and 90, and the participants with missing data were excluded. And the index date for the patients with lung cancer was the date of first diagnosis. And also the model performance of the age cutoff was less than 55 years and more than 55 years. Now the screening of the at the age cutoff year or age was revealed as superior, that is 0.871, as compared to those obtained with the cutoff age of 50 or 60 years. The analysis of the subgroups, the third subgroup was both the age and the gender matched, and those of the ages above and below 55 years and with or without lung disease. So this model revealed an AUC of 0.818, and in contrast, it provided strong performance for individuals above the age of 55 years. And they exhibited low positive value for individuals less than 55 years and with no history of lung disease. Now, this is the table which shows the final results of the whole population, then the age and gender matched above 55 and below 55 years, history with history and no history of lung disease, then the combinations of the age above and the lung disease history, and with no history, I mean all the 4 permutations, combinations of age and history of lung disease. And here you can see that the patients with a history of lung disease has a higher AUC, and also patients above 55 years has a higher AUC as compared to other groups, which was the major observation of the study. Now, coming to the discussion, in this study, the possibility of predicting lung cancer using a CNN with the diagnosis and medication history extracted from the electronic medical records as the main data source was explored. And this model can be used to as a means to evaluate the healthcare databases and also perform efficient population-based screening. Also, this approach has a potential to improve the accuracy of these current screening methods because it can identify those most likely to benefit from the interventions. And unlike other proposed lung cancer risk models, this study did not rely on the self-reported parameters such as the various habits of smoking, cessation history, and family history, the socioeconomic status, or the BMI. Now, here are a few various other models and previous studies which has been discussed in this article. A few of them to name are this Haggart model where AUC was 0.71, then the Liverpool Lung Project model where the AUC was between 0.67 to 0.82, and the Lung Cancer Risk Assessment Tool, which is achieved in AUCs of 0.77 to 0.78. And also the iron Omferman model also, the AUC was about 0.88. Now, an established computer vision model or the exception model to extract high-level features from the array representing the individual case histories was incorporated in the present study. And this featured a deep learning approach and achieved a prospective prediction of 0.87 in patients with older than 55 years of age and 0.90 for the entire patient cohort. And however, this study it serves as a proof of concept of using CNN with non-imaging medical records and comparing the performance of this model to that of different machine learning models of practical interest would be an interesting approach for further studies. Now, coming to the limitations of the study, this data collection was limited to only the NHRD database of Taiwan, and so the target population, which it was fairly homogeneous and with limited ethnicity, that is different races and ethnic were not included in the study. Also, the patient records did not include the tissue histology, which is the characteristic diagnostic feature for any cancer and of course for lung cancer also. And lung cancer staging data was also not included here. And this data set also did not contain any information regarding the smoking status, which is, habit being a very important risk factor associated with lung cancer development. And also self-reported information was not included in the study, such as the family history of smoking, and duration of symptoms, which are said to be valuable information for the clinical history taking. And they're also very important, which can help to improve the prediction accuracy. So a combination of all these can from the, if available from the medical records, will definitely help to improve the accuracy. So to conclude, this model exhibited a robust performance with respect to 1-year prospective prediction of the risk of developing lung cancer. And this model may be employed as a means to analyze various medical databases. So it may pave a way for efficient population-based screening. And also in future, a randomized controlled trial may be required to improve the clinical benefit of this model in diverse populations. Now, the impact of this research was that it can be readily deployed to evaluate the healthcare databases and also to perform efficient population-based screening of risk prediction of lung cancer. Thank you one and all for your patient hearing.
Thank you so much, Dr. Divya, for such an insightful talk. Now, I would like to start the question answer session. During this, you can write your questions using the messaging feature. So, right now, I have two questions. Both are from Nupur Biswas. So I will read the first question, and then you can answer, and then we'll move to the next one. So the first one is there any specific reason of why the older data, like the data before 2012, were used for training?
I didn't find any specific reason in the article as such. I think they have kept the based on the medical availability of the medical records. They have kept that as the date or index date or the deadline date for medical records.
The
That is
second
what.
question is okay. The second question is what medical information was used?
Only the medication history and the history of diagnosis. Only these two medical information was used from the records, and that was as I mentioned, that was a major limitation of the study, where other factors like the staging of lung disease, the histopathological diagnosis, the confirmatory histopathological diagnosis, and the patient's smoking or habit history, all that was not included in this study. So that was a major limitation. They have just taken the diagnosis and the medications history with 4 years of data.
Okay, I hope that answers your question, Nupur. I think that's it for the questions. Now, I would just like to announce you the next presentation. So, Dr. Divya, if you can move to the next
Yeah.
slide. Okay. So our next presentation, it will be given by Shruti, and it will be on 4th of October. And it is based on an article that is titled as Development of an e-health tool for capturing and analyzing the immune-related adverse effects in cancer treatment. Thank you so much for attending this CellTalk webinar. See you in the next presentation. Thank you.